First thing we want to start with today is talking about osmolarity, in particular how osmolarity relates to dry eye disease.
When you're evaluating a dry eye patient, whether it's in preparation for cataract surgery or refractive surgery or any ocular surgery or just as an ocular surface disease patient standalone, the most important thing is what's going to help us best predict what the problem is. Dry eye is an inflammatory disease based on the international definition, and hyperosmolarity was part of that new definition. As published in 2007.
Our understanding now of the more intricate workings of the pathophysiology of the disease have increased and certainly evolved over the years. But the hyperosmolar component of dry eye disease has been well known for a long time. And now we have at least a very good practical means of measuring it and following it.
Whether it's evaporative, whether they have lid margin disease, whether it's aqueous deficient, at the end of the day, they're getting hyperosmolar. We have something that actually correlates to the severity of the disease and correlates well to the response to treatment, I think is really critical.
People want numbers, clinicians want numbers, and just like cardiologists use body mass index, diabetologists use A1C, as ophthalmologists and eye care providers, we need to use some kind of number to help gauge and predict how the patient will do. A predictive value of treating dry eye is so important, and you need to have that in a quantitative fashion.
We have so many patients that come in and have conflicting data. They may have a normal tear breakup and a high Schirmer's, or normal Schirmer's and conjunctival staining or corneal staining. I think that having this tool is so critical, just from the standpoint of you know where you're starting and you can follow it over time. But like you mentioned before with having numeric values, it's sort of like when you're following a diabetic, you don't check one random blood sugar and use that as your means of following the diabetic. You need to get these blood sugars over periods of time. And the same thing with this dry eye osmolarity test. You want to see where they are. They're going to bounce all over the place in the beginning, and gradually you get the average to start coming down, and more importantly, you get the range to tighten.
It improves our patients' compliance with their treatment regimen. And having now a true barometer of disease progression and watching that come down, the patients seem to be more responsive and compliant with therapy.
Some of the studies have shown that one of the hallmarks of dry eye disease is a wide variation in tear osmolarity. Patients who don't have dry eye disease tend to have a very low range of tear osmolarity, which tends to be 300, and patients who have dry eye disease tend to have a very wide swing. So just because they may get one measurement that appears to be in the normal range and another measurement that is all over the place, let's say way in the severe range, doesn't mean that the test is inaccurate. That actually is helping guide your diagnosis. When that variation starts to tighten up and you start to get more consistent numbers, that is actually your response to therapy.
I wanted to reference the screening study that we did, a prevalence study. In that study, almost 50% of the patients had a high osmolarity. And when you subgroup looked at it with patients, contact lens patients, patients on glaucoma drops, post-refractive patients, post-cataract patients, they were all right around 50%. And interestingly, of the asymptomatic patients, they were about 44% had a high osmolarity. The normal group, which was the group under 308, and then the other group was the group above 308. If you look at the lower group, these people, they may have averaged in the 280s, but if you checked them from time to time, they'd be 280, 281, 283, 279. And you look at the high group, they might be 305, 335, 320, 350, big intra-eye difference. The normal group had an intra-eye difference of about 4 points. The other group had an intra-eye difference of about 15 points. I don't remember the exact number.
Well, it's that subset of patients that comes in that doesn't know they have dry eye and doesn't realize that variability of their vision, the halo and glare at night. They think it's that they need new glasses, new contacts, or that they have a cataract when it's really ocular surface disease. And it's where this test objectifies the diagnosis